Good evening, everyone. Hi, I'm State Senator Liz Krueger, and welcome to my webinar on good medical care as we age. I am delighted to be here with all of you tonight, at least virtually, and we have a really terrific presentation lined up for you. But I want to start, as I usually do, with reminding everybody that you are either on Zoom or on Facebook or calling in for the first session of my 2022 Boomer Senior Roundtable Series, Aging in Place, Living Well in the Community. We're going to have a 7-part series which will focus on some of the issues we need to address to age in place. Future roundtables will focus on being solo as you age, technology, making your apartment age friendly, and I hope that you're going to be able to join us again for one or more of the future roundtables in the series. As always, we have closed captioning for this evening's event. As a viewer, you have to activate your closed captioning to view the text on your device. If you're watching us in Zoom, click on Live Transcript at the bottom in the meeting controls and start viewing with closed captioning. If you're on Facebook Live, you will see a settings button in the bottom right-hand corner of your video. Click Closed Caption CC to start viewing closed captioning. This forum is being recorded, and everyone who RSVP'd will receive an email of the link to the video within a few days, and of course it will be up and running on my websites for any time you would like to watch it. As always, we start out with a few COVID updates and reminders. As you are likely aware, many hospitals in New York are overwhelmed due to staffing shortages and a high patient volume, including here in our city of New York. The State Health Department urges you to do the following in order to help reduce the number of people going to a hospital emergency department. Please do not go to the emergency department for COVID-19 testing, since this takes up emergency department staff and resources. There are a variety of accessible COVID-19 testing sites in every community of the city, and you can also get tested in your home. Please see the link in the chat to help find testing sites and to schedule a COVID-19 test in your home. Please do not go to the emergency department if you have very mild symptoms, which are a lot of people now because they'd already been vaccinated and boosted, and they're just getting sort of a breakthrough case. So if you have mild symptoms, if you have a runny nose, mild cough, mild sore throat, please stay in your home and treat this problem the same as if you had the flu. Try to drink plenty of fluids and, watch something mind-numbing on TV as you get through this. To help protect older adults in nursing homes, Governor Hochul has announced new visitation rules. So effective yesterday, January 12th, all visitors must wear surgical-type masks and must present upon every entry to a nursing home a COVID-19 negative test result taken within 24 hours of their visit. Last week, the CDC has made an additional update to its guidance on booster shots. If you received the Moderna vaccine as your primary series, you are now recommended to get an mRNA booster shot, Pfizer or Moderna, 5 months after your second dose. And now we are going to move on to tonight's event, Good Medical Care as We Age. We are very fortunate to have a wonderful speaker who hails all the way from San Francisco, although she went to college in New York, so as far as I'm concerned, that makes her a New Yorker. And of course, we have wonderful healthcare providers in New York, but I did want you to hear from Dr. Perissinotto, I think I screwed up her name, who is one of the best thinkers on older adult healthcare and who understands what good patient-centered healthcare should look like for older adults. Her colleague, Dr. Matthew Rowden, was also going to join us this evening, but is unable to be with us for a really good reason. He and his wife welcomed a brand new son into the world just the other day, and so he's on dad duty. We wish him and his new family health and joy, and he kindly offered to join us in the future. We'll probably take him up on that offer. Dr. Parasinoto is making an encore appearance with us this evening, and we'll talk about primary care for older adults and what you should expect from your primary care doctor. She will then share information from Dr. Groudon about medications and polypharmacy, taking more than one medication at a time, and how you can talk to your doctor about your medications to best achieve your healthcare goals. These are so confusing. This is so important. Just to remind you before we start, you can submit questions through the Q&A functions on Zoom and Facebook. After the presentation, I will moderate the Q&A portion of the event. And now it is my pleasure to introduce Dr. Carla Parasinoto. Hi, Doctor.
Hi, thank you so much. And you actually did quite beautifully. You just have to, it's like Mississippi. There's a lot of letters when you get there. So
There is.
All right. Well, I am going to go ahead and share my slides. So give me 1 second. So this is always the fun part. And yep, except we went the wrong way. Hold on. I got to start at the beginning. And then we go here. And now we are. We good? We're good, I believe. Okay. So it's so lovely to be here again with all of you. I wish it could be in person, but alas, I am in San Francisco. We've titled this Good Healthcare for Older Adults. And what I put is it's what we should expect and frankly, what we should be demanding from healthcare as we get older. So I am actually a geriatrician and a palliative medicine physician. So this is what I devote my work to, is taking care of us as we get older. I'm going to go through a little bit of background of what do we need to understand about the complexity and heterogeneity of aging. We'll then talk about some key topics central to our health, which includes the topic that Matthew Groudon was going to talk about, which is polypharmacy. And then, kind of interspersed through this is how can we actually advocate for our own health and what you can do now to think about protecting your health, your well-being, your quality of life, and for some of you, longevity. So central to all this, unfortunately, is the idea of ageism. It's an unfortunate truth, but I felt like I couldn't go on with the presentation without saying that, unfortunately, ageism really abounds, and it is interspersed throughout our entire healthcare system. Some of you may have experienced this personally. Some of you may have seen it in your parents. And some of you, like for me as a physician, I see when some of my colleagues are unfortunately ageist towards my own patients. And it's incredibly discouraging, either in terms of negating, not offering treatments that may be appropriate, and sometimes offering things that aren't appropriate despite someone's age. I will also comment that there's a really interesting article in the Lancet, actually titled Ageism, a Social Determinant of Health that has come of age, and really talking about how the UN and the World Health Organization are really trying to look at this issue of ageism globally. So this underlies, unfortunately, what we're going to be talking about today. I also wanted to sadly talk a little bit about the reality about what's going on in medical education. And again, starting with the fact that ageism abounds. And then what many of us may not be aware of is that just geriatrics and the specific teachings about the health and healthcare of older adults is not necessarily a mandatory part of medical school or residency. So to give you an example, for me in medical school, I had to spend 12 weeks in pediatrics, right? And if you think about the lifespan, that is maybe a quarter or less of our life. And yet I had maybe 2 weeks of geriatrics. So that should give you a little bit of framework as to why, as we get older, we actually have to be really thoughtful and careful about the care that we get and be advocates for ourselves, because many physicians, unfortunately, are not well trained in how our health changes and our body changes as we get older. This is also to say that not all education is created equal. Some medical schools are actually much better than others at geriatrics. You guys are lucky to have Mount Sinai in New York, which is one of the premier institutions for geriatrics, and NYU similarly has an amazing geriatrics group. And then again, not all clinicians are created equal, in that some are going to be better served to take care of you than others. And that's unfortunately the reality of the world that we live in right now. So the question often comes up is, do you need a geriatrician? Well, I have to say that I'm biased because I'm a geriatrician. And so I happen to think that we're particularly good at what we do. But the reality is that there are too few of us. There's essentially one geriatrician for 7,578 people over the age of 65. So that is way too many patients for me to take care of as a sole geriatrician. So what does that actually mean? Well, that means that there's a couple things, that there's a lot of work that needs to be done on the policy side to think about how do we encourage more people to go into geriatrics? How do we think about healthcare payment reform in terms of how we compensate physicians, and not just physicians, but people interested in aging? And if we don't have enough geriatricians, how can we at least improve our healthcare system so that they're safer for all of us? What does it mean to be older? And this gets to a little bit, do you need a geriatrician? Well, this is tricky. So geriatrics really means the care of older patients, but older is not necessarily a cutoff by age. So really often for me, when I think about who I see, it's more about physiological age. So I have my oldest patient is 105. I've had patients as young as in their 20s because they are homebound and have multiple medical problems that are functionally making them as if they're much older. So it's really thinking about, how is your health? Is the person that's giving you healthcare thinking about how to promote your health as you get older? And if you're already starting to experience some frailty or some changes in your function, do you have the right team members that can help to preserve your function and or keep you from getting worse, and in fact, even help you improve? So what does this all mean also? The reason we focus so much on function is the following. So the function really is about how independent are you able to do activities every day, or how much extra help that you need. So in a younger person, if we think about what helps, if I consider myself to be younger, I'm 43. So at my age, the things that help me stay active and independent are what is going on with my medical health, my physical health, what's going on cognitively, emotionally with me, in my environment, my home environment, what affects me, what's going on socially and familially and financially. So all of these affect ultimately me as a person and my ability to be independent. What happens as we get older is that many of us are actually living with chronic conditions. We have problems in some of these other domains, whether that be economically, environmentally, and then ultimately that leads to functional decline. And so what happens as we get older is that all of these circles actually affect us more, much more than they do as they get younger. So that if you have a problem in one, it can affect others, and it affects our ability to stay independent. And this is something that is very core to the geriatrician, or how I see older adults, is you have to think about all of this together. So really, as a geriatrician, my primary focus is to think about the person as individual. What kinds of help do they need, or do someone need help to stay independent? What is the person's health goals, and what's important to them in terms of the quality of life? And then I really work in an interdisciplinary team. On the right is an example of a very high functioning pulmonary clinical team that works with older adults, that has nurses, physicians, nurse practitioners, pharmacists, patient coordinators, therapists, all who are working together to help the patient. So this is really the framework by which you think about what is good care for older adults. Now, the other part I want to highlight, and this is in some ways an introduction to a talk you'll have in your series, I believe next week, if not coming up shortly, which is really a concept put together by a couple different organizations, one of them being the John Hartford Foundation and the American Geriatric Society. And really what they talk about is that what we do as geriatricians, or what we need to do to really have age-friendly health systems, is to think about the 4 M's. I've expanded it to 5 M's here because this includes one of the competencies for medical students and residents, which is 1, we want to focus on the mind, 2, mobility, 3, medications, 4, multi-complexity or morbidity, and then 5, what matters most. And we're going to go through this through the lens of myself as a clinician, and for you all as potential patients of the healthcare system. Alongside of this, what I want to highlight is something called the Choosing Wisely campaign. The Choosing Wisely campaign is actually this phenomenal subset of the American Board of Internal Medicine, which says that there are things that providers and patients should question, which means There are things that we have done in medicine routinely for a long time, if not question it, but it's actually time for us to question them and say, is that really necessary? Is there evidence? Can it cause harm? Is it necessary? And will it actually help me? And so this is something that I also wanted to give you some tools to understand about this. So let's talk about the mind. So when I see my patients in clinic or at home, since I see homebound adults, very often I have patients that ask me that are worried about their memory. And the question is always, is this normal aging? Is it cognitive impairment? Is it dementia? Is it depression? Is it delirium? All of these things kind of can overlap. But to give you some information, and for some of you, allay some fears, and for some of you, it may prompt you to get a little bit of evaluation. So the most common thing I hear is that as we get older, we had word finding difficulty. You forget a word, you forget someone's name. Okay, that is actually incredibly common, and it can be a normal part of aging. As we get older, the main problem we have is recalling, which means accessing the information. It's not recognizing the information. So it may be that, you can't think of something right away, but if your friend or your wife says, "Oh, do you remember that thing?" "Oh yeah, of course." Then the memory comes back to it. That's just a problem accessing and getting the information out of your brain. That can be normal as well. And then the other thing that happens as we get older is we have more trouble with difficult tasks when we're distracted. So for example, if I'm with my mom, she has to finish texting before she can talk to me. She can't do both at the same time. That's actually very normal also. It's also probably not good for us to multitask, but that's a different story. And then we just happen to process information a little bit slower, and that is also normal. The problem is when this moves from normal age-related changes to dementia or mild cognitive impairment is when it is affecting our everyday lives. When we're forgetting appointments, forgetting medications, forgetting to pay bills, that's when we move into something more serious. Now, why is this important? So interestingly and unfortunately, thinking about the medical care that you're getting, anywhere from 27 to 81% of people in primary care have unrecognized cognitive impairment. So that is a really big issue. In some of the clinics that I've looked at, it's as low as 2% of people. So this is a big issue. Now, the problem is also that if we have cognitive impairment, it affects our life expectancy, and it potentially puts us at risk for elder abuse and people taking advantage of us. A good thing for us to know, although it can be daunting for us as we get older to have someone test our cognition, is that having your cognition assessed is actually included in the annual wellness visit. Now, unfortunately, which this gets back to the beginning of my talk, not all clinicians feel comfortable assessing cognitive impairment, though there are initiatives statewide and by state to help improve the training of clinicians in identifying cognitive impairment. Why is this important? Is again, one, it can either reassure us and say, hey, those memory lapses that I'm having are actually normal. Two, it could help us if we find something, say, wow, do I need to review my medications? And is there something that could be doing this? And three, if it is real, and if we are starting having changes, it can also help us prepare, set up things like our advanced care planning documents, and prepare to have people help us in case we have more impairment that is leading us on the road to dementia. If we get back to the Choosing Wisely campaign, there's a couple things that are important here. So for example, one of the things is do not use benzodiazepines, which are things like Valium and Ativan and Klonopin or other sedative medications as a first choice for insomnia, agitation, or delirium. The reason being is that there is a plethora of data and research that show this class of medications actually increase our risk of dementia and increase our risk of falls. There are other recommendations, which unfortunately you would be surprised to see, but there are unfortunately many older adults who are still restrained in hospitals because they are having behavioral changes or acute confusion, and this is really distressing. There's also another Choosing Wisely campaign by the American Academy of Nursing who says, Do not assume someone has dementia, because what can happen to us as we get older is that how we present with an illness is actually that we're confused. That doesn't mean that we have dementia. It means that there's an acute change and failure in the brain, in the same way that we can get heart failure, kidney failure, lung failure, that it can happen to the brain temporarily. So what can we do right now to protect our brain and our cognition? So amazingly, there's actually very good literature for socialization. Socialization is a broad term. It means connecting with others in whatever way that means to you. I know that's difficult with COVID, but that does, socialization can be as simple as talking to someone on the phone. It does not have to be completely in person. Physical activity, that also doesn't mean running a marathon. It means increasing the physical activity for you. If you're someone who's usually sedentary, even doing some amount of physical activity will help. The third thing is medication review, and we'll talk about this a little bit more in detail. And the fourth thing is undergo an evaluation, which I stated as part of our annual wellness visit. So moving on to the next M is mobility. So why do we care about mobility, function, and frailty? So we know that mobility affects our quality of life. It's also a better predictor of whether you will become institutionalized and need long-term care. Some people prefer long-term care and don't want to live independently, so that's okay. But for some people, that is not something that's desired. It is also a predictor of hospital mortality. So more than what other illnesses you have, it's often your underlying frailty and function, which is a predictor, which we often don't talk about enough. So what does this mean, and what does this mean for your healthcare providers and what you're getting? It means that on the annual wellness visit or at other times, your healthcare provider should actually have an understanding of how you're functioning. Do you need help on a day-to-day basis? Can you get your medications? Do you have transportation? Do you have equipment that you need in your home to live safely? Is your provider assessing for falls, which is looking at what devices you're using, how you're walking, and again, reviewing medications? You will see this be a central theme. And lastly, if you have fallen, working with an interprofessional team, which often involves physical therapy, to make sure that you are really being managed in the best way possible to prevent further falls. So what can you do right now to preserve your function? So I will again talk about socialization. These things are very intertwined. Physical activity, again, it's the use it or lose it philosophy with our muscles. Medication review, same as the last section, and then undergo an evaluation again. So something that many of us don't know is that if we have fall risk, you actually can get a home safety evaluation by home health, which can be paid for by Medicare. This is often underused, but it is something that can be done. And they can look at your bathroom, your bedroom, other areas to see, are there any modifications you can do to keep you safe? If you're doing fine right now, it can also help protect for the future. My mother is 78. She's pretty healthy, but she has some mobility limitations. And some of the things that we've done ahead of time, because her daughter's a geriatrician, is to make some slight modifications to her home so that we're not doing it when we're in crisis mode. They're not modifications that make her feel like she's getting older and that are very obvious, but there's slight things like changing the shower head, adding a bench in the bathroom, slight things that can make it so that she can stay in her home longer. And so that if she does fall, if there's a crisis, we're not dealing in it at the last minute. The last thing I would say is to think about transportation options in your area. And I'm sure the senator and her staff have ideas for you for your area in terms of what's available for you. So the next part is probably one of the biggest and most important parts of this talk, which is really about medications, polypharmacy, and prescribing. So we'll spend some time. These slides are from Dr. Grouden, but we'll talk about why polypharmacy is actually potentially harmful. It is defined as taking 5 or more medications, and then we'll talk about prescribing and what that actually means. I have to say that as a geriatrician, when I consult at times for other clinicians, one of the biggest reasons I get consulted for by patients rather than by other doctors is polypharmacy, is the sense of I have too many medications. I don't like them. I feel like I don't know why I'm taking them, and I don't know if they're helping me, if they're causing me more harm. So I get this a lot. So if you feel this way, you are not alone. Right now, we know that at least 50% of older adults have more than 5 medications, and that's what defines polypharmacy. And then unfortunately, our risk of having an adverse drug event is increased by 15% when you're on 2 medications, 58% when you're on 5 medications, and 82% when you're on more than 7 medications. I will tell you that I think most physicians or clinicians underplay the problems with polypharmacy. And the reason being is that we are trained historically as physicians and clinicians to treat each illness individually and not all together. And when we look at research, most of the research, for example, will look at if you have heart failure, this is what you need to take. But they don't look at, for example, what if you're 85, have falls, and have diabetes, and have cognitive impairment and heart failure? What do you do? None of those studies exist. And so that's why we're getting into problems, and why many of you probably have these long lists of medications. And then what happens is that each individual doctor tells you, well, this is really important for your kidney, this is really important for your heart, but no one's telling you what is important for you and what the risks and benefits actually are. So how common is polypharmacy in the US? Well, we know that here in the United States, at least 40% of older adults take 5 or more prescription medications. 20% or more take more than 10 medications, and then over 66% take more than 5 medications, include over-the-counter medications and supplements, which often aren't included in the counts. Now, the reason why this is important is that about 750 people are hospitalized every day because of medication side effects, and this is often not communicated. So for example, someone will go in with a fall, but they won't say, well, actually that fall was because they were put on this sedative medication. And I see this unfortunately routinely. We also know that over the last decade, there's been older people who are seeking medical treatment for more than 35 million times because of adverse drug events. So this is a serious thing. And again, it's not talked about enough. So going back to the Choosing Wisely campaign, this is where we have to weigh the risks and benefits of medications. Is there evidence for my condition, for my situation? Are we extrapolating data? And what do I do here? So we know that research has very clearly linked polypharmacy with possible bad outcomes. It doesn't happen with everyone, but it is possible. Reduced quality of life, and many people feel this. Challenges in taking medications correctly. I mean, I've had trouble with some of my patients figuring out how do they actually figure out how to take these things. Adverse drug reactions and side effects, drug-drug interactions, which is also underplayed, incredibly unnecessary costs. There's very medication-specific harms, falls, as I mentioned, hospitalization, and cognitive impairment and confusion. Now, polypharmacy and the risks of medications are not just with prescription medications. In fact, some of the most dangerous medications are over the counter. And frankly, in my spare time, I want to be writing to our major drug chains and pharmacy and drug companies to tell them that we should be having black box warnings in some of these things, which we don't. So for example, some of the very common medications that many of us use for sleep have things called PM. Now, any medication that has the word PM has an ingredient called diphenhydramine. You can see it here outlined. That is the same as Benadryl. Now, Benadryl and diphenhydramine are one of the worst medications for us as we get older. It absolutely increases our risk of falls. It absolutely increases our risk of confusion, and in men causes urinary retention. Now, this is not anywhere on the label. No one tells us this. And unfortunately, I have many physician colleagues that put their patients on this, and I get really, really upset about it. So I am bringing this to you so you can be aware of this and you can tell your friends that this is something harmful. So this is over-the-counter medications. The other class of over-the-counter medications, which can be problematic and not always, are supplements. There's this assumption that because it's natural, it is safe. That is not always true. There's a couple things. So for example, St. John's wort is a medication that is a natural medicine supplement that people often use for depression. However, it has huge interactions with other drugs. The other problems with supplements is that they are not regulated by the FDA, which means that even though SolarAray says that this has St. John's wort, there's no one actually checking to see that that's actually what's in it. And that's what can be problematic. The other problem with supplements, and for full disclosure, I have had patients that come with me with a long slew of things, and I'm not as familiar. Sometimes I have some websites where I can check to see for ingredients and things that are obvious, but I can't always confirm. And so that's a risk that you're taking with not knowing what's in it and if it interacts with other medications. So this is just something for you to be cautious of. I know many of us like to take supplements and vitamins, but just to be thoughtful about what you're taking and that we don't actually know. Other important things about over-the-counter medications. So antihistamines or allergy medications, some of them can affect cognition. So especially the sedating ones, they can also affect our blood pressure. Cough medications have been shown to be abused by younger people, interestingly. And then we know that pain medications, actually more often, people tend to worry about Tylenol. It's actually ibuprofen and Advil that is incredibly problematic to the kidneys and can cause bleeding. And we don't always know that. Sleep aids, as I mentioned, affect our cognition. Laxatives can affect the electrolytes in our body and give us cramps and cause kidney problems. And then decongestions can raise our blood pressure. So these are things that are just out there that you don't need to talk to a physician about, but can actually harm us. So getting back to the Choosing Wisely campaign, one of the recommendations we make is do not prescribe a medication without conducting a drug regimen review. However, this is a warning and a special note to all of us. Unfortunately, do not assume your doctors talk to one another. I wish I could tell you differently, but it's just often not true that we talk to each other. We sometimes do, but we do not. And this is what creates unsafe areas. I will also say that, often, especially if your physicians are in different healthcare systems, we're not always aware of what someone else has put you on as a medication. And accessing your record is not always as simple as you could be, or the record is so complex that it's actually really hard to find this information. So this seems like this should not be true in 2022, but it is. And so I'm giving this information to you if you're not already aware of it, because really you have to be in charge of your own health and your own medications. Even myself, I am a physician. I have gone through with my physician many times what medications I'm taking. And every time I look at that list in my record, it's wrong. So it's important for you to really think about what do you have at home and how do you make that comparison. So what often happens, even though it's a recommendation that clinicians conduct a medication review, it's often done haphazardly and not actually the right way. The number of times that I've seen medications in a medical record and then I actually go to someone's home, it is often very different. And this is a scary state of affairs. So I wanted to just point that out to you. The other reason medications are important to pay attention to is that as we age, medications affect us differently. This gets back to what I said earlier, that unfortunately in our medical training, we are not taught about these physiological changes with aging. In pediatrics, we learn about dose-based or weight-based dosing. We do not do that for older adults, and this is where we get into trouble. I have seen this in my own parents. I had a father who had a fall and died from a fall, I truly believe because of polypharmacy and because of incorrect dosing. And this is a sad state of affairs that I'm a geriatrician and it happened to my own father. It's also true that medications that may have been good for us years ago are not the best choice now. Okay. There are things even like conditions like diabetes, where we have been taught for decades that our lower A1C, which is our average blood sugar, is better for us. Well, that actually changes over time. And that is one of the things I have to talk a lot with my patients about, that actually, as we get older, particularly over 80, and particularly if we have other medical problems, lower is not necessarily better. And this has been shown repeatedly that actually a little bit of a higher sugar is actually probably safer. So something to know. Sometimes I get in disagreements with endocrinologists about this, but this is something for us to be aware of. There is actually a whole list of medications. There's something called the Beers criteria that you can look up, which actually shows a list of potentially unfavorable medications. Now, if you go to this and you compare your medications, you're going to say, oh my goodness, I shouldn't be on any of these. So that's not always that you shouldn't be on any of them. It's more that sometimes in combination or in doses, they're a problem, or it means that we have to watch these over time for side effects. So it doesn't mean, oh my goodness, suddenly stop all your medications, because that's not safe. It's just like, I need to think more clearly about what is happening here. So what can you do about polypharmacy? So the main thing is, can you talk to your provider about deprescribing? So what is deprescribing? It actually is a systematic process of identifying and discontinuing drugs. So when I have my patients, I'm going to explain that in a second. It means thinking about potential harms and benefits and when they start to outweigh the risk. And then it's also making that decision in the context of a person's individual goals, their current functioning, their life expectancies, their values, and their preferences. So when I have patients, it's not like I suddenly stop everything all at once. I think about, okay, what are the most risky things? And based on this person's goals, what can I safely stop? And I may do one at a time. There are sometimes that things are so dangerous that I have to stop more than one at a time, but it's very slowly. Sometimes, because there could be withdrawal from medications, it's incrementally going down. So this is a whole process with outweighing the risks and benefits. So let me give you an example. I've had patients that have heart disease and heart attacks where they've been told they need to be on an aspirin and a stronger medication, but suddenly they're having bleeding. So my job then as a clinician is to talk to my patient and say, okay, what risk do we want to accept here? My concern that an acute bleeding episode is actually going to be more dangerous for your health right now than the long-term benefit of aspirin protecting from your heart, depending on your life expectancy. So if I have someone who I think is so sick that they only have a few months to a year, a couple of years of life, I'm going to make some difficult decisions, and we do that together. So that's something that I do often. Okay. So what can you do? Talking to your clinician about, why am I taking this medication? What are the potential benefits and harms? It may be worth you doing some research on your own, asking about if it can affect your memory and cause you to fall. Unfortunately, again, many clinicians aren't aware of all these side effects, which is why I'm trying to empower you with some of this information. And then thinking about, sometimes it's just reducing the dose of a medication, and how do we keep track of it? This is some guidance from the Canadian Deprescribing Network, which has a whole process for this. And then after you've started doing that, it's really about the prescription checkup. So taking an inventory of all the medications you're taking and why. Sometimes that's how we get at it. It's like, wow, I don't even know why they're on that medication. Okay, let's stop it. Thinking about, is the medication beneficial and why? And then thinking about how to slowly taper, and then following up. Is it safe to do this? Absolutely, yes. You just have to do it with some careful and thoughtful processes and some follow-up. I have had times where we've tried to deprescribe and taper, and we realize actually this isn't going well, and we have to go back up. This is part of the process, but at least we try. So, for example, an example is many older adults now, or people in general, getting put on acid reducing medications, and then they never get taken off. So what I do often is like, okay, well, why don't we move it to as needed and then see if you really need it? So that's how we manage it. There's a couple other resources I will share with you, and I believe we'll be able to share the slides for you at a later date, or I'm not sure exactly. I'll let the senator let us know after, but there's different ways for us to really learn about how to do this. So to summarize, what can you do right now? Review all your medications, consider deprescribing, make an appointment with your physician. For some of you, the pharmacist may be more useful, and then thinking about questions or making a list of potential side effects. The next M is really geared a little bit more towards medical students or our clinicians, but I wanted to just introduce the idea. The idea is that as we get older, we may have multi-complexity, which means that there may be multiple illnesses and factors in our lives that affect our life expectancy. It also reminds us that because of this, hospitals can be dangerous, because suddenly we go for one thing and all our organs end up being a mess, We have multiple specialties involved, and then our chances of our getting better just get more complicated. It also reminds us that our sensory function in terms of our hearing and vision are so central to our health also that we have to think about this. And then we also know that with multi-complexity and aging, that illnesses present differently. And we actually saw this early in COVID. And I think we missed probably some early cases of COVID because older adults were presenting just with fatigue and confusion and not the usual signs of a respiratory infection. And they presented much more sick. So what all this reminds us of is that we have to think about how do we individualize recommendations, and do you have a clinician that can really think about you as a whole person? I will end this section with a quote by Mary Tinetti, who's a very well-known and respected geriatrician from Yale, who says, "The time has come to abandon disease as the focus of medical care." And more importantly, she says, "The changed spectrum of health, the complex interplay of biological and non-biological factors, the aging population, and the intervariability in health priorities render medical care that are centered on the diagnosis and treatment of individual diseases at best out of date and at worst harmful." And if there's one take home that I can give you today, is that it's really important to think of ourselves holistically and not as our individual illnesses, because that's where we get into trouble. So what can you do right now about this? Be thoughtful about hospitalizations, and not all of them are preventable, but if you do, think about what can you do to keep yourself the safest when you're hospitalized. If you have hearing impairment and visual impairment, make sure you have those things to protect yourself from getting confused in the hospital. Do you have a plan for who's going to be able to help you afterwards? If you don't have a plan, is there home health that can help you at home afterwards? Review the purpose and the list of all your specialists. I think my medical colleagues may not agree with me or may not be happy with me because I'm taking away business, but often as my patient's geriatrician, one of the things that I do is despecialize and think about, do you really need all those specialists? And why are we doing this? It doesn't work for everyone, because some people have very complex illnesses that have that, but others have had specialists over time because of habit and they don't really need them. Do not assume that your specialists talk to each other. I wish it were different, but that is actually the case. And because of that, I would say it's really important for you to keep your own records and bring someone with you to an appointment when it's allowed, if you think it's too much information for you to manage and you need someone else to also record. This goes along with the idea that as we get older, it may be hard to process all that information at once, and it can be overwhelming. So having someone else there as a second set of ears and eyes can be helpful. During COVID, I know there was a question. I have seen people get more sick because they're avoiding medical care. So I think it's still important to keep in touch with the most critical parts of your healthcare team. That may mean familiarizing yourself with tech if you need to be able to connect virtually. So do not ignore the visits, okay? The last section and where we'll end is really about what matters. So unfortunately, years ago, the idea of what talking about matters really got misnomed as death panels. But really what I think about this is that what matters most to your health, to all of our health as we get older, who do you want present to help make decisions? It also means for children, if there's any children on the phone who are taking care of older parents, is remembering that parents may still want privacy and autonomy. And just because they're older doesn't mean that you as a child get sole rights and can speak for them. Sometimes you can, but I've often seen, unfortunately, children that forget to ask their parents what they want. I've seen this during COVID, and I've seen this at other times. This is a chance for us to really think about in the years that we have, and they may be long or they may be short, how do we want to spend our life? How do we preserve our health? And when do we decide that enough is enough? It involves managing symptoms if we get sick, and understanding priorities. Sometimes the priorities that we have may be difficult and different from our family or from our physician. I will share personally that during COVID, I had some discussions with my mother. My husband and I had discussions with his mother, and we were very shocked to hear some of the answers in terms of what their priorities were, which may have been different than what we thought their priorities would be. But without having those discussions, we wouldn't have known. And similarly, even though, again, as I said, I'm 43, I've had these discussions with my husband and my close friends also in terms of what's important to me as I get older, and should I have a life-threatening illness that comes up suddenly or that doesn't, so that my family and my clinicians can respect my wishes. Okay. So the reason why I state this is that thinking about advanced care planning is important in all stages of our life, and it changes over time, and it's not just with serious illness. An example of this is with a patient of mine who said that she was designating her daughter as her surrogate decision maker. And what she told us was very clearly that she wanted to focus on quality of life and not necessarily longevity. She was willing to undergo some treatments, but she didn't want to take a lot of pills or medications. She wouldn't want surgery for lung cancer if there was an early cancer or if she found anything on cancer screening. Now, the reason why this conversation is helpful for me as a clinician is that for me now with Ms. Lopez, I can decide and go through her medications with her and say, okay, these are things that are going to be life prolonging. And if you don't necessarily want to be on these, we can stop them. It helps us talk about when can we stop some of this cancer screening. There are times that we are doing cancer screening where it's no longer appropriate, either because of age alone or because someone has so many other medical problems that are more likely to take their life than the cancer screening that they don't necessarily do that. I take care of a young gentleman who's 65. No, actually, he just turned 70, who unfortunately has metastatic liver cancer. And we had a really tough discussion recently because he said, I realize I need to have colon cancer screening. And I thought it was really awesome that he was taking charge of his health, as I had told him. But I told him, unfortunately, your life expectancy is really short from your liver cancer. And the risk of the colon cancer screening are too big, and they're not going to actually benefit your health. And so we had to have that hard discussion about his life expectancy and stopping that screening. So diving a little bit deeper, many of us clinicians tend to overestimate someone's survival, but by a factor of 3 to 5. We're better at being better at short-term prognosis than long-term. And then often if we have long-standing relationships with our patient, this clouds our judgment. So just something to be aware of that. And then getting back to the screening question, as I said, we have to be thoughtful about what cancer screening we're recommending, depending on what other illnesses someone has and someone's life expectancy. So that means there may be some really difficult conversations. I wanted to highlight some documents that some of you are probably already aware of, which is a POLST. I think it may be called a MOLST in New York, which is what are your preferences for resuscitation? I highlight this, but I want to remember that when we talk about what matters, it's not just about life-sustaining treatment. It's about what matters to you. I have a patient recently who said, if I could listen to jazz, my pain would be better controlled. Hey, that's what matters to her. And that's what I'm focusing on. And I worked to find her a radio at her boarding care so she could listen to that. So what can you do now? Really take some time to think about what's important to you. If you're able to document your wishes formally, that's even better. Be prepared for some difficult conversations, sometimes with your family and sometimes with your physician. Some kids don't want to talk about this. My sister refuses to talk about this with my mom, and so it's me who talks about it. And then reminding that it's still important for us to be hopeful about our future. So some final takeaways, and then we'll open it up for questions, is that, this is really about how do we advocate for ourselves as we get older? How do we advocate for more age-friendly health and healthcare systems? And then keeping this framework in mind about how do we preserve our mind? How do we preserve our mobility? How do medications impact all of this? It really makes me mad at how bad we are in pharmacology as clinicians. How do we manage our multiple medical conditions? And then how do we make sure that we are expressing what really matters most to us? And with that, I think we will be done, and we will open it up to questions.
Well, that was amazing. Thank you so much. I have a million questions, but we're not going to go to my questions right now. Although probably we all want to know why you're a doctor in San Francisco and we can't just use you as our doctor here in Manhattan. But
I was close to Sinai, but the snow, I told you.
Oh, I know. All right. We love telemedicine, but probably we still want to aim to actually have a doctor a little closer.
Mm-hmm.
All right, so many questions came in, but we had lots of questions that came in earlier. So, is it much better to find a geriatrician, or is your regular internist okay as you approach age 80?
Yeah, so I think this really depends on, what kind of health issues you're dealing with. If I ruled the world, I would make more geriatricians, because I think that our focus on how we think about someone, not just as the conglomerate of illness, but as a person who has a community and a life, that's a really nice framework. There are some amazing internists and family medicine doctors that have this viewpoint. It's more about, have you noticed whether your clinician can help you get into some of these areas of understanding the importance of function, understanding the importance of your cognition, and being really thoughtful about medications. I think medications is one of the areas that I think is the biggest gap between people trained traditionally and then people trained in geriatrics.
Great. How can those of us who are sheltering far from our usual medical providers due to COVID maintain a high level of medical care from afar?
Yeah, I think this is where, if you're able to, let me put it this way. I think healthcare systems or clinics are trying to be thoughtful about who needs to come in and who doesn't. However, I have seen some, and I won't name names, that they've happened here in San Francisco, that were so worried about older adults getting sick that they kept all the older people at home and brought all the young people in, which I thought that's the opposite. Keep the young people healthy home and bring the older people that need the care in. So it's about, it's probably a way of triaging. So maybe you're used to seeing someone every 3 months. Can you space it out a little bit? Can you see your primary and not all your other ones? So can you do some by virtual visits? So there's still some touch points I really think you have to do, because I have seen, to be frank with you, some deaths because of missed medical care and some worsening of illnesses because of missed medical care.
So even though I know you touched on this with doctors not checking in with each other or knowing what the other's prescribing, but what would be the best way to coordinate the care if you're seeing multiple doctors who may be associated with multiple hospitals?
Yeah, so I think there's a couple things here. I think keeping your own records is actually incredibly important, and literally a chart. It doesn't have to be typed. It can even be written out. Like, this is the medication prescribed by this person for this condition. It can help keep things straight and bring that to your appointments. Some medical records do talk to each other, but there's so much information in them that it can be really hard to sort through. And then I would really ask yourself, do you really need that physician? I have patients with very simple heart problems that are, for example, atrial fibrillation, that is simple, or hypertension. You don't need a cardiologist. Your regular doctor can manage that. So it's really thinking about, do I need all these specialists? More specialists sometimes brings more confusion and not necessarily better care.
No, that's a very good point. My dad's doctor keeps saying he's doing great for his age, which is not helpful.
Right.
He is great and he needs interventions. But after that phrase, the doctor seems to tune out and rejects ideas for any kind of necessary help. Please comment, especially to the doctors. Thanks.
Yeah, so I think that this is an interesting comment, because I can see these both ways. I think that there could be a little bit of ageism on the doctor side, in terms of like, oh, you're old, you're fine. Like, there's a funny cartoon that I saw once, and it's an older gentleman who says, my right knee hurts. And the doctor says, well, you've been walking on it for 96 years. And he says, yes, but my left knee doesn't hurt. And I've also been walking on it for 96 years. So there's this part about, it's not just age. But I would caution the daughter, I think it's a daughter or son, that we have to be thoughtful about, more is not always better. And sometimes we want to do interventions to older adults and we're not actually sure what the benefit is. And it's making sure for this person's dad, do they want these interventions or not? So sometimes we're doing things for ourselves in terms of, we want our parents to live longer, but they may not necessarily want it. So it's having those conversations. So it's a little bit of both. And sometimes it does require advocating. I've had some doctors that won't do procedures on my patients just by age. And I say, hey, this is actually an incredibly functional, very active 85-year-old woman. This is actually very appropriate for her to have this screening. And so I have to advocate a little bit more.
Got it. So a couple of questions related to depression. So what if the patient is declining life-saving treatment because of untreated depression? And then I'm going to combine that with a second question. What do you do to help the person fight through depression so that they will want to take care of themselves?
Yeah, so I think this is a really tough area, and probably an area where we don't have enough research in terms of the treatment of late life depression. I do think that there's more need for specialized geriatric psychiatry care. And so if someone really has unmanaged depression, it's seeing, have you had the best access to both a geriatric psychiatrist and truly good behavioral health? Declining treatments, I think this is also an area where you have to get expert opinion to really try to figure out, is it the depression that it's acting, or is it really someone's wishes? I wish it was a little bit more black and white, but it's tricky here and very nuanced.
Thank you. It is, I think, very nuanced. Is there some master list that we should know about for what our annual check with the doctor should be when we're seniors?
So this is an interesting area because I think for years, we were all used to having annual labs, annual EKGs. None of that is actually evidence-based. And so it is actually, and I will tell you, for example, things like listening to our heart and lungs, it's totally habit and not actually something that's evidence-based and needed, but I think it's a way to connect with your patients. There is something called the annual wellness visit, which I think is getting in a better way, which is actually focusing much more on what we should be doing, which is, how are you functioning? What is your cognition, and what health screenings should we be doing? But so that is actually published in terms of what should be included in that, but it's still variable. But there's still no, Carla Parasinoto, when she turns 65, should have a blood count, a chemistry. There's none of that. That doesn't exist. It's still an individualized part, which I think is important. I know that there's some things that I know I won't. I'm a physician. I'm a difficult patient that I won't do. And so I went to my doctor recently. She's like, "Oh, right, you're a physician. I remember you're going to be difficult." I'm like, "That would be correct." So, yes. Yep.
Okay. So most of us want to manage our own medical affairs, but what are the telltale signs that they may no longer be possible?
Yeah, so I think it depends on what the medical affair, what managing means. So this gets to, there are times, even for my mother who's 78, who manages her own affairs, but sometimes she wants to run things by me. She wants me to talk to her physicians just to make sure she understands, or she gets overwhelmed and wants to, and English is her second language. And so she'll want me to run things by. So there's that part where you just need kind of a sidekick to help you. Then there's the issue of when you need someone else to have it. That's more of an issue with capacity. Do you have capacity to make that decision? And that's really when you do not understand the risks and benefits, then you should have someone else manage it. But usually if you're getting to that point, you're not even aware of it, and someone has to do that for you.
Thank you. Okay, so hospice care. All right, so does it have to be in your own home, or can it be somewhere else, even in a relative or friend's home, or even in a different place from where you live?
Yes to all of the above. I actually am currently a hospice medical director, so that's also what I do. I think an important thing that people do not recognize about hospice. So hospice is a Medicare benefit that covers the nursing services, the social service, but does not cover room and board. So for example, if you weren't able to be in your home and needed to be in a nursing home or an assisted living, that is out of pocket. Medicare does not pay for that. But if you were living in New York and you have a terminal diagnosis and your children or your friends are in Colorado, you want to move to Colorado, you can move to Colorado. It's just a matter of establishing with a hospice agency in that other state. So, and I have certainly had patients here that choose to move into with another family member during that period.
Great, thank you. How can the role of the home health be improved so as to create a better quality of care for the homebound? So I guess they're talking about the payments in Medicare and Medicaid for home health care.
Yeah, there's a couple parts here, I would say, because there's home health care, which is like a short-term skilled need like nursing and physical therapy. There's also a movement towards more home-based primary care. And actually, Mount Sinai is one of the premier institutions that has a home visiting doctors program, which is phenomenal. There's a lot of work being done nationally and policy-wise on this. So the American Geriatric Society is doing work on this. There's also an organization called the American Academy of Home Care Medicine that is working with this. So there's a lot of work. Part of it, I think, involves better training of clinician and better policy around this, because there's actually a lot of companies that are starting more home-based care. It's just a matter of how can we ensure it's the right quality. So a lot of work being done nationally is a short answer. And so keep active and advocating.
My wife and I are 88 and 87. We are mobile, but our abilities are worsening. Our 2 children take care of us very well, but they have their own families and can't be with us all the time. What can we look forward to?
Mm-hmm. That's an interesting question in terms of what you mean you can look forward to. I think it's trying to prepare for the future in terms of what are you most worried about? Are you worried about what kind of help are you going to need help with? I also think it involves having great conversations with your children. I think sometimes as we get older, we assume that we're a burden, and we're not always. Sometimes we are, but not always. And I think, I've had experiences with kids where they say, I wish my parents asked me for more help because I'm willing to do it, and others where it's just not possible. But I think it's more about, as you're getting older, what are you anticipating? Is it meal preparation? Is it self-care? What are the finances? Can you really think about concrete tasks so you can plan to think about, can you rely on your kids for some things and for professionals for others? We are actually seeing some, for example, Medicare Advantage plans starting to support more at-home care for companionship. So those are some encouraging things coming down the pipeline as well.
How would you recommend we find good geriatricians?
Yeah, so if you are in Manhattan or in the area, I think that you have 2 phenomenal institutions at your disposal that have a phenomenal group of geriatricians, and that's specifically Mount Sinai and NYU. Cornell does as well. Columbia, not as much. I don't want to offend anyone, but that's my understanding, and that's where I know my colleagues are. The American Geriatric Society also has a list of geriatricians. I will also say that there's, depending on preference, it's, some people are board certified because they were able to take a test into it, or just by time they're grandfathered in. Others have been fellowship trained. But I will again say that think about, if you're looking for a geriatrician, what are the needs that aren't being met by your current clinician? And is that something that can be addressed, or do you really need to change? And then let's continue to talk about this horrible ageism that's preventing more people from going into geriatrics.
Right. Could you talk a little bit more about the issues of calcium and osteoporosis? I have heard a number of digestive medications used for acid reflux actually reduce the calcium in our bones, which leads to osteoporosis.
Yep. That's a complex question, but I would say that yes, that's absolutely true. In recent years, there's more and more people put on these medications called proton pump inhibitors. So omeprazole, Protonix, those kinds of classes, they absolutely do affect osteoporosis. And so that's where you have to think about, do I need that medication or not? And it's a risk benefit. I will also say that I'm think that in many cases, there's studies showing that vitamin D is probably more important than the calcium. Because without vitamin D, you don't absorb calcium, and then you take in too much calcium and you get it out through your kidneys anyway. So it is complex. And this is one of the things that, again, this is why we review medications to see, do we really need it?
Right. And how about that 81 milligram of aspirin that everyone over 40 seems to be taking?
No, and actually, there's more and more research in recent years for primary prevention, and especially in women. If you do not have an underlying reason for heart disease, you should not take it. The risks outweigh the benefits. So this is something that's definitely falling out of favor.
Got it. Thank you. I swear, I think everyone I've known, like who's over,
yeah,
I don't know, having children is
Yep.
being told to take the baby aspirin.
Right. And I think it's thankfully starting to change. And again, the risks are higher for women. And so women without an underlying reason should not be on it. Yeah.
Okay. I don't know how you would actually know how to answer this, but I'll read it to you. Under the heading of not all clinicians are created equally. In general, do you believe doctors in Manhattan are better than those in Queens? Doctors I have tried in Astoria tend to leave after a year or two.
Ooh, I don't want to start any turf wars here. So
I know.
what I would answer instead of this is very humbly that it is a very hard time to be in healthcare. And our burnout is incredibly high, and our burnout in primary care is high. And so I think people leaving are because the work burden and what is expected of primary care physicians is insane. I think this probably relates to, there's a question somewhere I saw about what is good email etiquette for your clinician. I think what's important to recognize is that we are asked to do a lot of work after hours, and that is unpaid. And unpaid, that's a complicated thing. Are physicians well compensated? Yes, but given the amount of work, it's really problematic. And so I think that this is one of the issues where, rather than specialty, even, it's about what is expected for us. So, a lot of what us in geriatrics are trying to do is advocate for, you cannot expect an older adult to be able to get through their medical issues and get good care in 20 minutes. That's just horrendous. And it's just not kind to anyone. And of course, we're going to have bad outcomes. And so that's what we need to change. So really think more about, I can't tell you it's a location issue. It's really about the state of our field, and why I think many of us are trying to advocate at a national level and policy wise for reform.
Right. So this is a person who's concerned that it's better not to write down their wishes in advance, because if it's in writing and the situation changes in your favor, but you can't express that you've changed your mind, you could have a real problem.
This is a nuanced here, and I'll answer it the following way. There are important things to write down in terms of what's important to you. Not necessarily are you DNR, DNI, but what is important to you. So for example, for me, what's important for me that I can communicate with my family and that I can recognize them. Okay. That should be the guiding principle. And within that principle, that should guide the person that I designate as my decision maker to be able to make those decisions. If the situation I'm currently in is not going to allow me to meet those goals, then that's when the situation should change. The problem with not writing them down or writing them down is that if we're in crisis, if in my healthy state or when I'm in the same state, I can say, I know I don't want to be on a ventilator because I don't want to die that way. But in the moment, if I'm, very scared and can't breathe, I'm going to ask for that, even though that's not my wish. And so that's where it can be really tricky. So it's more important to think about your overall values and who in your life do you think can represent your values. I have seen bad situations where it's not written down, where family oversteps and tries to keep people alive, or the reverse against someone's wishes, and that can be tricky. It's muddled, it's complicated, but it's about talking about this.
Right. I don't always have someone to go to the doctor with me, and I'm not great at remembering, so I use my cell phone to record the meeting. But I found some doctors will ask me not to do that, I guess fearing a lawsuit. Is there a law against this? I usually just ignore them and tape them anyway.
Yeah, so you'll probably get the risk of getting people to label you as a difficult patient. I think I don't know that actually don't know if there's a law, if it's like espionage about recording
No,
people.
in New York State, as long as one of the two parties knows they're being taped, you don't have to tell the other one.
Okay, so interestingly,
one of those states.
I think it's important disclosure. I mean, I've had patients ask me, yes, of course, it's the fear of, unfortunately, our fear of litigation is huge. I understand why my patients do it, and I've been fine with it. But unfortunately, yeah, that is a preference. I think it's more, that's more of a sign of unfortunate, lack of trust between you and your clinician. If you can't have a conversation about that, that feels right.
So if your doctor's records have errors in them, that could be problematic if you're brought to a hospital in emergency. Do you have the right to look at your records to double check that they are correct?
Yeah, so there's more and more laws that are about open records and being able to review your notes. Where it gets tricky, frankly, is when people disagree with the diagnoses, and that's something that what is correct and what's not. Okay, obviously, if you had your right arm pain and it says left, that's something that wants to be corrected. However, I've had situations where I know that someone has cognitive impairment, I've tested, and they don't want me to include it in the medical record, or they don't want me to include depression, and that's problematic because that's actually my assessment and based on what I do. So it's nuanced here. So there are opportunities to correct it, but it just depends on, on what. You can't disagree with some of the diagnoses unless there's very clear evidence for that.
Right. How can us older folks deal with generic medications that change in shape and color all the time? And it's hard for us to identify or remember what they look like from month to month.
I know. I wish I had a better answer for this. I don't, other than I think there is important for you to be able to recognize and make sure it's the right medication that you're getting. And usually on the pill bottle, it'll say like R32, this is lisinopril or whatever it is. But these things this is the sad state of affairs of pharmaceuticals in this country and what we're doing. I wish I had a better option for you, other than figuring out what the best system is for you with pills and pill bottles to make, or pill boxes to make sure that you're taking things appropriately.
So it is 8:10. There are just requests and questions pouring in, and I don't even know how to separate them out at this moment. There's so many of them. So I think it highlights how important this work is, how important your work is, doctor. And I so appreciate your giving us this time tonight. And it highlights, yes, we need to make sure we have more access here at home to geriatricians for ourselves and for public education. And again, I want to wish your partner well in his life. I so appreciate your giving us this time, representing both you and him. I want to assure people that the webinar will be up on the websites, and yes, you can, if you want to share them with other groups, somebody just asked me that, you can talk to my office and we'll make sure we help you be able to share them with other groups you might be involved in, and that we will try to do our best to help you with these questions on your own behalf. I just want to mention, I was supposed to mention these before, so just very quickly, if you're looking for help with insurance issues, we highly recommend HICAP,
Great
the
resource.
Aging Health Insurance Information Assistance Program at the Department for the Aging. We've actually had them on another webinar. They can help you find the best insurance option for yourself. We know that many of you are having challenges finding doctors who accept Medicare. So we're also listing the best contact information we have on the chat site, and it will also be available on my website. Finally, my senior resource guide, which you can get a copy of by calling my office. If you don't have one now, I'll happily send you a copy. Has a lot of information that you may find helpful. And our next event will be next Thursday, January 20th, from 10 to 11:30 in the morning. The 4 M's, a framework for an age-friendly healthcare system.
You guys will be experts. That's great.
We'll be experts. That's right. We'll give you tests by the third one. The presenter next Thursday will be John Hartford Foundation, who will discuss initiatives to promote an age-friendly, patient-centered healthcare system in New York State, and also from a Northwell doctor who is participating in the Hartford Foundation's age-friendly emergency room pilot program. So we'll also learn more about that. And please remember to wear your masks in indoor settings, get vaccinated, boosted, and have a great rest of the evening. And thank you so much again, Doctor, for signing in with us here in New York. Very much appreciated.
Absolutely. Thank you all.
Everybody have a good night.